Good afternoon, everyone. My name is Ed Kinsella. I'm the Secretary for the American Bladder Cancer Society, and I'd like to welcome you all this afternoon. We have Dr. Jason Estafew with us this afternoon. He's going to speak on the bladder sparing protocol at Massachusetts General Hospital for invasive bladder cancer. And we'd like to welcome Doctor with us this afternoon. He has a short presentation for us. I asked him before he started if he minded taking questions during the presentation. If folks would like to submit questions, if you can just type them into your questions panel, I will monitor them on the computer and then we can provide it to Doctor. We have the audio response from the participants muted so that we don't get feedback from various devices. So if you do have a question for Doctor, just type it in and we'll relay it to him and we'll get an answer for him. So with no further ado, I'd like to introduce Dr. Estafew to you folks this afternoon. Doctor?
Great. Thank you very much. And also thank you for the invitation by the American Bladder Cancer Society to talk about bladder sparing therapy. This is a nice opportunity, and as was said, I'd be happy to answer questions during the presentation as well. So I am a radiation oncologist at Massachusetts General Hospital and work with a large collaborative multidisciplinary team on, if we can go back, with a large multidisciplinary team taking care of bladder cancer patients. And so again, today I'll be focusing on bladder sparing therapy. Organ conservation, or the preservation of an organ, is actually now commonplace in oncology in general. With a number of cancers, that being the primary modus operandi. So anal cancer, breast cancer, breast conserving therapy, esophageal cancer, cancers of the larynx, sarcomas. Prostate cancer has options where radical surgery are not needed, and this indeed now applies to bladder cancer. So in bladder cancer, cystectomy has been the gold standard. Though alternatives have emerged in the last few decades aimed at bladder conservation. The goals between either cystectomy or bladder preservation are the same. Number one, we want to cure the patient, we want to optimize survival, we want to prevent failure and recurrence, and we want to provide good quality of life with what we would call a functional urinary reservoir. So what is that modern alternative to a radical cystectomy? It's what we call trimodality therapy. And it really is an important combination of treatments. So a maximal transurethral resection of the bladder tumor, what we call a TURBT, is needed. Ideally, this is visibly complete, meaning that the urologist, when they have done that resection within the bladder under cystoscopic guidance, that they actually don't see any residual cancer left. Then radiation therapy along with chemotherapy is used. Next slide, please. And here's sort of a schema of bladder sparing therapy. It starts with a transurethral resection, as I mentioned, and then a course of radiation and chemotherapy, a break for a few weeks, and then another look by the urologist by cystoscopy, asking the question, is there any tumor there? Is it persistent? Has it recurred? And if it hasn't, we continue with what we call consolidation chemoradiation to a full dose of radiation. If, however, there is evidence of persistent or recurrent tumor, involved throughout this process of initial diagnosis and resection, the cystoscopic surveillance that's required both during the treatment and in follow-up afterwards, and indeed in those who haven't responded to that treatment, the need for a salvage radical cystectomy. These are just some of the fields of radiation. I won't spend too much time on it, other than the yellow refers to the bladder, the red is the tumor within the bladder, and the lighter red is the lymph nodes in that region. And these are just some of the fields that we use in radiation when we're designing what we call conformal therapy to treat what we want to treat and avoid normal tissues. This here is an example of, again, what we call a boost field with radiation, where we're delivering the highest doses, focusing on the red, which is the bladder tumor within the bladder. So the MGH and at the Massachusetts General Hospital and our national cooperative group called the Radiation Therapy Oncology Group have a long history in attempts at bladder-sparing therapy and in studying it as well. And so if we look back at the mid-1980s when this really started, we were using neoadjuvant chemo followed by chemoradiation, and we first introduced the idea of the response evaluation. That was that break 2/3 of the way through treatment where we look, is it actually working before going to completion? That was introduced back then. In the mid-1990s to the late 1990s, we were looking at accelerated radiation, in fact delivering radiation twice a day instead of just once a day. And then more recently, in the more recent years, we've been looking at what we call enhanced radiation sensitization. What chemotherapy or other drugs can be used that make radiation even better, give you a bigger bang for your buck, basically, with each treatment. So that's sort of just a sense of the evolution of this treatment over the last 3 decades or so. We have now published our long-term experience at the Massachusetts General Hospital with bladder-sparing therapy. And this was recently published this year, looking at 350 patients with muscle-invasive disease who were treated on these protocols that I was referring to. The median age of the patients was about 66 years. They were followed for a long time with the, so to speak, average follow-up or median follow-up of about 8 years. Currently now that's over 9 years. And we looked at survival as primary endpoints. So, as is typical for bladder cancer, 3/4 were male, a quarter female. Most of the patients or half of the patients we looked at had what's called T2 disease, muscle-invasive disease. But we also looked at more advanced disease that's invaded into the fat around the bladder, that's T3, or even into other organs, like the rectum, or the actually in this case, the prostate, which is T4A disease. Most of our patients we're very fortunate to work with urologists who do these maximal resections up front, and 2/3 of our patients had that visibly complete resection by urologists. And that actually requires working very closely with urologists so that they feel comfortable to do as maximal and as complete as possible a resection up front. Next slide. Sorry. I just looked so similar to the last slide. Over 78% of our patients have what we call a complete response, a CR. That means that at that look in their bladder, 2/3 of the way through treatment, they do not have any evidence of persistent or recurrent bladder cancer. That's pretty good, over 70%. Currently our rates are probably around 80%. The survival rates are listed here. If you go just up to the bottom of this table, you'll see that 29%, or let's say 30% of patients on these protocols still required a cystectomy for a recurrence at some point. Surgery, and that applies to maybe about 30% of patients. These are just graphs showing long-term survival. So again, they have data out to 15 years. This is very similar to what is seen after radical cystectomy up front. The data is very, very similar. And one of the things you'll notice between a radical cystectomy versus this bladder-sparing approach is that after 5 years, very few failures. Meaning, if you get to the 5-year mark, the chances of having a late recurrence are low. It's one of the criticisms of bladder-sparing therapy, since the bladder hasn't been removed. Are you subjecting those patients to a higher risk of a late recurrence later because they still have their bladder? I think it's a fair question, but this data suggests that that may not be the case. It's similar to cystectomy, that if your first 5 years show good results, that's likely to be durable. This shows that the approach works well in the elderly versus less old folks. So the red and blue lines, one is for age over 75 and the other is for under 75. And the results are comparably good. We can skip over this one. This is just breaking up our data. The top line, the red line is the T2 patients, so the muscle invasive. And the bottom blue line is the more advanced patients, those where it's coming from the fat or other organs. Obviously, the ones that are more advanced are going to do a little worse than those that are less advanced. That makes sense, and that's true whether you have surgery up front or bladder sparing therapy. The important thing is that 50% of our patients are not dying of bladder cancer even with more advanced disease, the blue line. 50% long-term, 15-year good results, and I think that's an important thing to know. This is just breaking up the data by those who had a complete response, the red line, versus those who didn't. It's a very good early indicator of how well you're going to do. Is that cancer sensitive to the treatments we're giving them? If they are, you're more so in the red line group, and if not, in the blue line group. And this just for background shows, I mean, many folks have started to talk about neoadjuvant chemo before cystectomy or chemo before bladder sparing therapy. And there is a lot of good data to suggest that in certain scenarios, chemo before cystectomy can make sense and may lead to better results. And that's still a point of debate, and it's being sorted out. But there's that data. In the world of bladder sparing therapy, our data shows there is zero difference. Basically, you don't really need to look at the graphs too close, other than the red and the blue are overlapping with it. You can't tell them apart. And so neoadjuvant chemo and bladder sparing doesn't seem to help. And next slide, please. That's been shown in a number of other studies. Again, the details don't matter so much, other than to say there really isn't any solid evidence suggesting that neoadjuvant chemo before bladder sparing therapy helps. And so we typically do not do that. I think we can probably skip over this one. Other than, if you go back actually just for 1 second, if you look at the yellow, complete TURBT versus not complete. Basically, long story short, if your urologist is able to have a complete resection up front before you start into chemo radiation, your results are going to be better. That doesn't mean that if you don't have a complete resection, there's some reasons why you can't. It's not just because they didn't do a good job. It's sometimes the tumor is so advanced that without doing serious damage, putting a hole in the bladder, something like that, a complete resection just can't be done. You still have good results, even if a complete resection can't be done up front, but they're not as good as if you were able to have a complete resection. That's basically what this is telling us. We've developed nomograms, and are you familiar with nomograms? Basically, a bunch of clinical factors to say, well, how well are we going to do? And so we've done that with our data from the Mass General. And these are being made available also to clinicians who are taking care of bladder cancer patients. I think I'm going to emphasize one thing, that selection of patients is key. Bladder sparing therapy is not really appropriate for all patients with bladder cancer. It is a good option, and it is a very viable option for certain select patients. And who are those patients? Usually those are the patients who have one tumor. This is what we've seen in our data. That has no hydronephrosis. Hydronephrosis is when you're blocking the ureters back to the kidney, and basically fluid builds up back to the kidney. The kidney isn't draining it as well. When there's evidence of that, usually surgery or cystectomy up front is going to be better. Similarly, again, while we've gone over a complete resection is better than not. If you have extensive carcinoma in situ, our approach is probably, chemoradiation is not really a treatment for carcinoma in situ. So if you have evidence of a lot of that along with your bladder tumor, we usually shy away from bladder sparing therapy and recommend cystectomy. Your kidney's got to work well so that you can take chemo. so that you know that a lot of the chemo we use is what's cisplatin is one of the main chemotherapeutic agents, and that requires you to have well-functioning kidneys in order to get that treatment. And transitional cell carcinoma is the main histology from the pathologist of most sort of the garden variety of bladder cancer. But there are other histologies, and there are rare ones. There's squamous cells, there's small cell, there's this, that. And we can't really say that bladder sparing is as good as cystectomy in those patients because we just haven't really done it in that many, so we don't know. So how does bladder sparing compare to upfront cystectomy? These are just basically a lot of caveats I'm afraid it's a pretty simple question, but it's actually kind of hard to answer that. One of the reasons it's hard is that when you do a cystectomy, you get more information about the tumor. And what we know, and studies from my group have shown this as well, that a patient who is thought to be T2, just muscle invasive, up to 30 or 40% of the time will be upstaged at time of cystectomy, meaning although they thought it was T2, it really turns out to be T3. Okay. Now, we don't get that extra information when we're doing chemoradiation because we're not removing the bladder and removing the whole tumor. And so sometimes what I'm basically saying is you're not comparing apples to apples. So there's a lot of caveats to comparing upfront cystectomy to chemoradiation. But if we do our best job, next slide, please, we'll see that if you just look at the 5 and 10-year rates, this is overall survival. So you have to remember a lot of bladder cancer patients are elderly. They're in their 70s, so they're going to die of other causes. So although some of these numbers look lower, this is not just due to bladder cancer. This is just 10-year survival based on all causes. But what you can see if you look at 5 and 10-year numbers in big cystectomy series from Southern California, Sloan Kettering, and others, compared to big chemoradiation series, is that the numbers are pretty similar. So for when you try to make apples to apples as best as possible, we think that chemoradiation offers as good survival of bladder cancer as cystectomy. There has been one attempt to actually do a trial comparing the two. And it's been done in the UK. The UK can pull off trials where they randomize a patient who comes to them with bladder cancer, for example, to surgery or something else. You can't really do that in the US. American patients aren't that willing to be randomized, especially when it's surgery or no surgery, right? It's a tough thing to accept. So these studies are actually very hard to pull off. And if you really wanted to answer the question, well, are they the same or is one better than the other, that's the kind of study you'd have to do, where it's a flip of a coin deciding do you have cystectomy or bladder sparing therapy first. They tried to do it in the UK, next slide, and it didn't work. They couldn't get enough patients to randomize. And so they had to end the study very prematurely. However, in the UK, bladder sparing therapy is the primary approach to invasive bladder cancer, interestingly, unlike most other countries. And what they were finding in this study is that most patients wanted, if they could choose, bladder sparing therapy. They didn't want surgery. And so this is the problem why they couldn't pull the study off. Patients weren't, again, in the UK, willing to be randomized. This is another study that we published in JCO, one of the big oncology journals, looking at, there are different ways to figure out toxicity and quality of life. One is, and I think the most important, is to ask patients quality of life. The other is graded toxicity. And this is typically done by physicians or members of the care team. And so we usually think grade 3 higher toxicity are the significant ones. Everybody's going to have a little grade 1 and a little grade 2. That's expected during these treatments. But so how often is grade 3 or higher happening with chemoradiation? And so in our protocols, we actually see pretty low. I mean, it's 7%. Grade 3 and nothing higher. Most of it is 6% is GU, 2% is gastrointestinal, GU meaning bladder, GI meaning bowel. So we consider this acceptable and actually low rates of grade 3 or higher toxicity. There are 2 comparative studies. They're a little older. One's from Italy, one's from Sweden, that looked at incontinent diversion versus chemoradiation. The other looked at continent and incontinent diversion versus radiation. And next slide. Long story short, if you were to kind of summarize these quality of life comparisons, this is sort of what they're going to tell you, is that there may be some level of quality of life advantage to chemoradiation over one of those types of surgeries as far as the issues listed here: psychological adjustment, physical well-being, energy, sexual function, urinary function. And there may be equivalence between them as far as social functioning and bowel functioning. Bowel functioning is typically worse with chemoradiation, to be fair. It's actually just in these studies, the rates were higher with chemoradiation versus surgery, but they weren't statistically different. So it's a little bit of I think one word to be fair, one would say bowel function is probably more affected by chemoradiation than it is by surgery. But, and here's another question, which actually was given to patients, which is an interesting one. This came from the Erlangen group in Germany, and amongst their patients they said, if you were to spend the rest of your life with your urinary condition the way it is now, how would you feel about that? And then they gave a number of options. It's a pretty simple question, actually, but very illustrative. And so this is after chemoradiation. And as you can see, most patients were pleased or mostly satisfied or even delighted. It's really a minority of patients that were dissatisfied or unhappy with their quality of life. So this has led to us saying that the best bladder you will ever have is the one you're born with. I mean, obviously this is a slide I use when I'm debating the urologist as to what to do up front. Obviously this is taken with the humorous, but so even if you had some radiation, I mean, if there's an attempt to preserve and if there's interest from the patient to preserve the bladder, I think there are options we can provide. And we feel now that acceptance of chemoradiation in modern bladder-sparing therapy is not really limited by high rates of late pelvic toxicity, and I think I showed you that quality of life data. Next slide. And this is just to show you a little bit of the very honest data from Sloan Kettering, where they did over 1,000 radical cystectomies, and they captured real morbidity data, okay, on a validated scale and all this. Next slide. And this is what they showed, is that about 2/3 of patients had more than one complication of some sort. Okay, 13% were that grade 3 to 5. Remember, that's what I was telling you. Grade 3 or higher, that's kind of significant toxicity. About a quarter of the patients required a readmission for some reasons, for some complication. And there was a 1 to 2% what we call perioperative or around the time of surgery mortality. So we actually got in touch with the Sloan Kettering group. Can you just click the slide one more time? I'll just highlight something perhaps one more time. Yeah. So we went to the Sloan Kettering group and we said, can we compare your morbidity data after those cystectomies? And those were cystectomies on what we call virgin bladders. They had never seen radiation. And can we compare those to remember the 30% of patients we do a salvage cystectomy after radiation, right? So here's the question is can you get away with doing a salvage cystectomy after the bladder in that area has seen radiation? And how does that compare to never having seen radiation? Right? So that's what we try to do. And again, if you look at grade 3 or higher, which is the red box, our data, which is on the left within the red box, versus Sloan Kettering, pretty similar. Yes, if you add up the numbers, it's 14 plus 2 plus 2, that's 18 versus 13. We had some higher grade 3 or higher toxicity, but it's not like night and day. I mean, these are comparable. So we felt that, because another criticism is, well, if you see chemoradiation and you need a salvage cystectomy, if you're one of those 30% of patients, have you limited that cystectomy? Are you subjecting yourself to undue level of risk and morbidity from that procedure? And this, which has just been published in the Journal of Urology, might suggest actually it's probably okay. We can probably do it well. So these are the last few slides. So when is a radical cystectomy really justified? I think radical cystectomy is a great treatment. Okay, I really do. What I do believe, though, is that patients should be presented with options, and they should be told about the pros and cons of either approach, and whether those options are actually appropriate for them. And we were talking earlier about the questionnaire that gets to this sort of thing from the patient perspective. But so a radical cystectomy, I think, is justified as an option when chosen by the patient after a full discussion of the alternatives. I mean, I think it would be hard for anybody to argue against that. I do think that it's also the best first treatment for those at risk, a high risk of local failure. So I think that means those who have hydronephrosis, remember the backing up of the kidneys, or T4 disease, where actually the cancer is invading in the male, for example, into the prostate, or into organs around the bladder. I think surgery is a better upfront treatment. I was saying it's a better treatment if you have a really poor bladder function. If your bladder is not worth saving, then you shouldn't try saving it, period, right? And some patients have horrible bladder function, whether it's due to their tumor or some other reason, and maybe up front they're better served by having a cystectomy. And similar with bowel function. If you have really underlying bowel issues, radiation could make that worse. I also think a radical cystectomy is justified as salvage after chemoradiation if chemoradiation didn't work. Those 30% of patients where it might not. So combined modality treatment, by that I mean bladder sparing therapy combined with some resection, chemo, and radiation, achieves a complete response and preserves the native bladder for the patient in around 70% of cases, while offering long-term survival comparable to contemporary radical cystectomy. Quality of life studies that I think I've shown have demonstrated that the retained native bladder functions well, and long-term toxicity of chemoradiation to pelvic organs is relatively low. The incidence of cystectomy performed for palliation of chemoradiation-related toxicity has been very low, meaning we created so many problems with our chemoradiation that you actually have to remove the bladder just to get rid, to deal with those problems that you create. That we really see rarely. The morbidity of a salvage cystectomy also appears pretty comparable to a primary cystectomy. I don't want to overstate that, but I think that was the data I was showing you, the comparison with the Memorial Sloan Kettering data. Next slide. Yep. So we feel, our group at MGH feels that these results support the acceptance of modern bladder-sparing trimodality therapy for selected patients. Selected, I underline that word, it's not for everyone, as a proven alternative to cystectomy. We're working on the best regimen still. That's what all these protocols are about, for the which chemoradiation can we do once a day radiation, that kind of stuff. And we're working on the molecular targeted therapy and the biomarkers that I mentioned earlier. And ultimately, and I believe this is my last slide, the contribution of selective bladder-sparing therapy to the quality of life of patients represents a unique opportunity for urologic surgeons, radiation oncologists, and medical oncologists to work hand in hand in a truly multidisciplinary effort in the interest of that patient.